Welcome to our Medicare and Medicaid at 60. Where are we now and what will the future hold? Panel. I want to thank our illustrious panel for their time today and those who are here for this conversation. I'm Matthew Gamble, and I'm a state representative here in Georgia, and I will be moderating this general session. I want to welcome everyone to Georgia and just say how much we appreciate being able to host NCOIL here in Atlanta. I did hear the comments a minute ago about the Buckeyes and Texas game, and I can't, got to be honest, I'm not really focused on that game. I'm thinking about the Texas versus Georgia game on Saturday over in Athens that will be coming up. So Medicare and Medicaid celebrated their 60th anniversary on July the 30th of this year, marking 6 decades of providing essential health coverage to millions of Americans. Today, Medicare and Medicaid cover over 100 million people, approaching nearly half of the United States population. And since their creation, both programs have evolved significantly and have undergone significant reforms. And certainly, opinions vary as to the wisdom and effectiveness of all these reforms. But now, particularly in our current healthcare and overall governmental climate, this is a great opportunity to discuss the evolution of the programs and the road ahead. Joining us today to discuss these issues are David Lipschutz, co-director of the Center for Medicare Advocacy, Andrew Johnson, my friend, policy advisor on Medicaid and ACA exchanges, Mark Hamelberg, Senior Vice President of Federal Programs at America's Health Insurance Plans, Nina Schaefer, Senior Research Fellow at the Heritage Foundation, and Laura Colbert, also a friend from Georgia, that is the Executive Director of Georgians for a Healthy Future. So in terms of the format, we will hold questions until the very end of the presentations today, and we will start first with David. So David, if you would please go ahead and share with us.
All right. Thank you, Representative. Can you hear me?
I can.
Well, thank you. Good afternoon, and thank you very much for the invitation to be here. I must say I'm a little disappointed that I have not heard the mascot of my alma mater mentioned from University of California, Santa Cruz, the banana slug. But I'll wait patiently until someone sings their praise. Thank you. So my organization, the Center for Medicare Advocacy, is a nonpartisan nonprofit dedicated to advancing access to comprehensive Medicare coverage for beneficiaries. We do this through individual representation and through systemic policy advocacy, and it is through this lens that we view the Medicare program. Before we get into the challenges of Medicare at the moment, let's pause to celebrate some of the successes we have seen over the last 60 years. Before Medicare, half of individuals 65 and over had no health insurance. The passage of the bill led to a dramatic drop in the poverty rate for older adults. The Medicare Act was key to integrating hospitals in our country. In 1972, there was an expansion of Medicare coverage to certain individuals with disabilities. In 1983, a hospice benefit was added. And in many ways, Medicare has set the pace for the rest of our healthcare system, and today covers over 68 million people in our country. Now, as many of you likely know, there are generally 2 ways that people can get access to their Medicare coverage. One, through traditional Medicare, also known as original Medicare, sometimes referred to as fee-for-service Medicare, where individuals can see the provider of their choice. Such folks usually have traditional Medicare plus something else. It could be a standalone Part D prescription drug plan. It could be a Medigap supplemental insurance policy. The other way to access Medicare coverage are through private Medicare Advantage plans, usually HMOs or PPOs. It is the significant growth in Medicare Advantage enrollment, the privatization of the program, that is one of the biggest stories and one of the biggest challenges in Medicare now and in the future. Medicare Advantage enrollment has more than doubled since 2010 and now enrolls approximately 54% of the entire Medicare population. And although there's a modest slowdown this year, it's projected to enroll about 2/3 of all beneficiaries by 2033. And it's easy to see why Medicare Advantage is so attractive to many. If If you own a TV and turn it on this time of year, undoubtedly you will encounter many ads touting the benefits of Medicare Advantage, including extra benefits, out-of-pocket cap, zero or low premiums. Many forces align that push people into Medicare Advantage, including the fact that it's one-stop shopping. You don't need to mess with the separate Part D plan or Medigap policy. Agent broker commissions that are much higher for Medicare Advantage enrollment than prescription drug plans and Medigaps. The trade-offs, though, between Medicare Advantage and traditional Medicare are not adequately explained in these commercials or generally to the public. Medicare is becoming more complex, more difficult to navigate, and it is more difficult for individuals to make fully informed decisions about their coverage choices. And the choices in Medicare are unequal. And by that, I mean one can get in and out of a Medicare Advantage plan on an annual basis, but those who wish to return to traditional Medicare in most states, if they are past certain time periods, will be unable to pick up a Medigap, a Medicare supplemental insurance policy. And many people make the mistake of thinking they can try out Medicare Advantage and later pick up a Medigap. Now, there are barriers to care in the Medicare program across traditional Medicare and Medicare Advantage. Happy to expand on some of those if there's time during Q&A, but we focus a lot of our attention on individuals with chronic conditions. Many people do fine in Medicare Advantage, but these aren't the folks who contact us. Those in Medicare Advantage face additional barriers not generally found in traditional Medicare, including provider network restrictions and extensive use of prior authorization, including over the last few years, as was briefly discussed on this last panel, the injection of artificial intelligence and algorithmic tools. Now, when it comes to prior authorization of Medicare Advantage, the previous administration made some modest improvements, and the current administration has flagged this as something they are focusing on. There has rightly been much attention in the media and by policymakers on prior authorization, which, in addition to trying to weed out medically unnecessary care, can have the tendency to weed out medically necessary care. There's been a lot of attention on prior authorization denials, but not enough attention to something that, in our mind, is just as important, and that's premature terminations of coverage. That's when a Medicare Advantage plan, for example, has authorized coverage, say, post-hospital stay in a skilled nursing facility, but the plan moves to terminate such coverage before the clinicians believe it is appropriate. We have helped individuals who had care authorized in Medicare Advantage plan in a skilled nursing facility who faced premature terminations of coverage, and very few people appeal, but when they do, they tend to be successful. But we have faced people who have received denials, appealed, won, and then receive another denial as early as the very following day. We have helped people appeal 3, 4, 8, 10 times during one episode of care for a skilled nursing facility stay. And unfortunately, none of the current reforms are targeted at addressing this issue. Now, at the same time, as noted by the Medicare Payment Advisory Commission, known as MedPAC, Medicare spends approximately 20% more for Medicare Advantage enrollees than it would spend if those beneficiaries were enrolled in traditional Medicare, a difference that translates into projected $84 billion in 2025 alone. This is due to a number of reasons, including favorable selection, coding intensity, and a quality bonus program that has not, in the aggregate, improved quality. This is an incredible strain on the Medicare program and beneficiaries. Part B premiums paid by all enrollees, regardless of whether or not they're in Medicare Advantage or in traditional Medicare, are increased by $13 billion in this year alone, according to MedPAC's projection, because of these significant overpayments. Medicare is facing fiscal challenges, in part due to an aging population and increasing cost of health care. The Medicare Advantage trajectory that we are on is not sustainable. We need a significant course correction to rein in Medicare Advantage overpayments and significant expansion of consumer protections and oversight. I'll skip over some of my remarks, but policymakers should ask what would be lost if Medicare becomes more privatized. We need to strengthen traditional Medicare, which can be done in part by reining in some of the Medicare Advantage overpayments. Now, looking more broadly at healthcare in our country and recent developments, in our view, the H.R. 1 is a step backwards. Now, H.R. 1 is going to mostly impact Medicaid, but it will have direct impacts on Medicare beneficiaries. Again, I'll save the rest of that for the Q&A given our time constraints. So why is this relevant to the folks in this room? Federal law preempts most state law when it comes to the oversight and regulation of Medicare. But I will close by mentioning 3 areas where state legislatures can be involved when it comes to Medicare. 1, states have the ability to expand rights to purchase Medigap policies. The federal law creates a floor upon which states can build, and many states have. You have the power to increase access to Medigap plans by expanding rights to purchase them. States can expand eligibility for and access to Medicare savings programs, which help Medicare beneficiaries who qualify pay for many of their Medicare expenses. You can both expand eligibility and streamline access to the programs, something that was suspended under H.R. 1. And finally, you can join your colleagues at the National Association of Insurance Commissioners who have petitioned Congress for more authority to oversee Medicare Advantage marketing. We'll close with that and look forward to the discussion. Thank you.
Thank you. Next, we'll hear from Andrew Johnson.
Thank you, Mr. Chairman. Always good to see my friends from Georgia, Chairman Gamble and Chairman Walker. So thanks for letting us participate on the panel today. I'm Andrew Johnson with the Centers for Medicare and Medicaid Services. I have the privilege of working with our administrator, Dr. Mehmet Oz, and the great team that we have in D.C. But my home is here, and so love being here this week and welcome you all to Atlanta. Given our topic, I'm going to focus a little bit on kind of the history of Medicare and Medicaid since as we celebrate the 60th anniversary. And so I'll walk through a little bit of the history and a little bit of the numbers to put some context to our discussion today around kind of where we are with enrollment and how these programs are operating. And then happy to get into more policy discussions as we get in the Q&A. 60 years ago, Medicare and Medicaid became law, making a promise of health care access to the most vulnerable among us, including older adults, people with disabilities, children, pregnant women, and low-income families. Before these programs, millions of older adults and low-income Americans had no reliable access to health care. Today, more than 150 million Americans, 2 in 5 Americans, rely on these programs for everything from preventive services to life-saving treatments. Getting in a little bit, I'll add a little context to the Medicare numbers from my friend David here. 62.7 million Americans enrolled in Medicare in 2024. That's 1 in 5, and that's up from 19 million when the program began. Since the creation of Medicare, the poverty rate among seniors decreased from over 28% to under 10%. Since the creation of Medicare, share of seniors with some type of health insurance rose from just 52% to nearly 100% today. Since Medicare, the percentage of seniors seeing a physician annually rose from 68.8% to 95.6%. No drug benefit for seniors was in place before Medicare. Now 90% have it under Medicare Part D or Medicare Advantage. 1.5 million doctors, healthcare providers, and suppliers participate in Medicare. 380,000 is the number of Medicare institutional providers, including hospitals, labs, and skilled nursing facilities. Medicare also played a key role in desegregation. Within months of the law being enacted in 1965, 90% of hospitals accepted black patients. That proved that good policy could also advance common good. I'll get into a little bit of the Medicaid numbers. Medicaid and the Children's Health Insurance Program cover more than 82 million Americans, including adults, pregnant women, children, and people with disabilities. 3 out of 5 of our nursing home residents rely on Medicaid to pay for their care. Since the creation of Medicaid, the share of low-income, uninsured children has decreased by over 88%. Infant mortality rates, while still not where we want to see them in America, decreased by over 77% since the creation of Medicaid. 41% of all births are now covered by Medicaid, and in many states that's much higher and even exceeds half. But it's more than just about the numbers. It really is about the beneficiaries we serve. We've seen so many cases, and I know you all as policymakers have seen so many stories where these important programs cover those in need in your states. Medicaid has also evolved and has really helped to launch coordinated care models to really help improve patient outcomes today. Both programs have expanded access to preventive services, prescription drugs, and life-saving treatments. For the past 60 years, these programs have evolved alongside medicine itself. From remote monitoring to telehealth, they've kept pace with the way care is delivered. But a program and promise designed for the 20th century need to be reimagined for the 21st century, and that's what we're doing at CMS. As we move into the future, CMS is building on the program's legacies and ensuring that these programs will continue to help future generations enjoy longer, healthier lives. We're seizing a generational opportunity to modernize these programs and protect them by crushing fraud, delivering value, embracing new technologies, and protecting taxpayer dollars. We're a great nation, and Medicare and Medicaid confirm that greatness by providing a promise, a lifeline of health and hope to the most vulnerable among us. And it's a promise too important to break because they've advanced the very promise of America itself. Thank you for letting me be here today, and I look forward to your questions.
Thank you. Next, Mark Hammelberg will share.
Thank you. Let's see if we can get this to... Oh. Well, not sure if the slides are advancing, but that's okay. Thank you. Oh, there we go. Thanks. There we go. So thank you for inviting me to be here today to talk with you about the history of these incredibly important and complex programs. It was actually 20 years ago on the 40th anniversary that I was actually working in the federal government, and at the time, the key issues of the day were the implementation of outpatient drug benefits in Medicare, the creation of Part D, and creating new rules for what at the time was a pretty sleepy niche program in Medicare called, recently at that time, renamed Medicare Advantage. So in a lot of ways, things have changed. In a lot of ways, they've stayed the same. Now, I don't know if it would be all that helpful, but maybe during possibly the discussion period, I'm happy to respond to some degree to some of the things that David mentioned. I think the portrait that he describes of the MA program is certainly not the experience that most beneficiaries have. We know that because of the satisfaction rates, the quality of care delivered. We also know that some of the numbers that he mentioned we think are highly, highly questionable and are really not believed by a lot of policymakers. And the recommendations would cause serious harm to 35 million of the citizens of your states who are enrolled in these plans. So happy to have more conversation about that. But what I'd like to do for the next couple of minutes is just take a step back and look at some of the broader trends that we've seen, certainly in the past 20 years, but also over the past 40 years, and in part because they really will influence what we're going to see going forward. So I've organized them into 6 buckets. Obviously, we can't go through all the details on the slide, but just to crank through them quickly. One of the first bucket is the wide range of strategies and tactics that have been used to try to control costs. As these programs have grown, cost control has clearly been, for policymakers, a critical objective. And that explains, in a lot of ways, the growth of managed care in both Medicare and Medicaid. It's the use of figuring out ways to best align incentives to try to reduce low-value care and eliminate waste and unnecessary care in the system. So managed care plans receive capitated payments, and the goal is to provide the appropriate incentives to ensure that only the highest quality care is being delivered. We also have seen at the same time a drive to also align incentives for providers, hospitals, physicians, manufacturers, and others. In the 1980s, we saw a major change in how hospitals are paid through the DRG system. That's carried forward throughout the economy. And I know NCOIL last year passed a model regarding Medicaid agencies entering in value-based arrangements. So value-based care is another variation on the flavor of trying to find ways to get the most cost-effective care in the system. The next two buckets of issues that I wanted to mention relate to part of the reason that we need to have higher or more control of costs. It has to do with the expansion of eligibility and the expansion of benefits. While there have been some changes over time, the trends over the past 60 years have been to expand people who are, well, start with benefits, expand the generosity of benefits, including, as I mentioned, creating for the first time, starting in 2006, outpatient drugs in Medicare, and then in the Inflation Reduction Act, in really taking effect last year, primarily making the Part D benefit far more generous. You now have non-medical benefits, oftentimes available in Medicaid, and even as a broader trend, eliminating cost sharing for preventive care. Now, there are lots of policy reasons for doing that, but they have also, by and large, affected the overall costs of these programs. We also have, in a similar bucket, expansion in the groups of people who are eligible for coverage and shifting the types of coverage that they're eligible for. So we had Medicaid expansion under the ACA. We've also had, just in general, an older population that's living longer, having more chronic illnesses. And among the things that is doing is increasing significantly the demand for long-term services and supports. And the Medicaid program pays more than half of the costs in this country for long-term services and supports. And one of the questions is going to be on a go-forward basis, is the program really structured to bear that burden? Do we need to think about different ways, especially as the demand for long-term care has shifted very much from institutional care to home and community-based services, and that creates a lot of challenges around workforce and so forth. The next bucket that I wanted to mention has to do with quality. It goes hand in hand with efforts to control costs. There's also been an acknowledgement by policymakers over time to make sure that those efforts of trying to get the most cost-effective care don't come at the expense of the quality of care that people are delivered. So we see a wide range of quality metrics and bonuses and other incentives that have developed throughout Medicare, both the Medicare Advantage Star Ratings program, various quality metrics within the Medicare Fee-for-Service program, Medicaid having quality rating systems throughout. The fifth bucket is certainly new technologies. I think we all are acutely aware of how those technology changes have both created cost challenges and opportunities for improving quality of care, for improving quality of life for people. New drugs, treatments, and devices, data sharing and analysis, a total evolution in how claims are submitted and processed and the programs are overall administered, changes in how plans and providers interact, and even extending to changes in how providers are, and plans to some degree are structured, including a lot of consolidation on the provider side. And the last bucket I'll mention is about access and choice. One of the objectives that has really driven the use of managed care over time was the desire to give beneficiaries a choice, and a choice to find package of benefits that best meets their needs. But in giving those choices, as been mentioned, plans do typically use networks of providers. So they need to make sure that those networks are sufficiently available to meet the care needs of the population. So we've seen a lot of rules develop over time in both programs to try to address those issues. So where is all this going when you look at those broad trends over the last 60 years, but certainly over the last 20 years? Well, I'll start with many of the issues that I've mentioned are going to really inform the debates going forward. Now, this is before the passage of the reconciliation legislation, but Medicare and Medicaid costs were projected to double by 2032. And a lot of that has to do with Medicare enrollment and rising healthcare prices and utilization. So while that the reconciliation legislation may change the trajectory somewhat, there's still going to be a major cost set of pressures that policymakers at the federal and state levels are going to have to grapple with. So that certainly means efforts to measure and reduce low-value care are going to continue apace. We're also going to continue to have advancements in care delivery. That's going to bring expensive drugs and treatments. Some of them are even cures, and others will be significantly improving quality of life, but the entire healthcare system is going to have to figure out ways that it can afford it over the long term. We're also going to continue to have pressure for expanding eligibility and benefits in Medicare for sure, like potentially for adding more basic benefits to the Medicare program. And states will likely continue to want to look for opportunities to add benefits in Medicaid to address barriers that many low-income people have to accessing care. But Medicare is already the largest single purchaser of health care in the United States. So, and when you take that into account, plus the broader changes in the workforce and the economy, there's a real possibility, acknowledging and the very significant political challenges, that there could be a need to rethink some pretty fundamental structural parts of the Medicare program. How it's financed, how premiums are paid by beneficiaries, potential changes around eligibility and benefits. AI has come up in several panels before, and is certainly going to, from where we sit here today, it's going to expand. How it's going to be used, from the development of new treatments, from other types of interventions, from identifying fraud, waste, and abuse. I don't think any of us sitting here today have a clear vision of how that's going to go, but it's going to be a major policy driver. Dual eligibles are almost certainly going to continue to be a big area of focus. They're a small percentage of the population, but they have very significant care needs and challenges in accessing care. So there certainly could be a renewal of efforts, for example, to possibly consolidate them into a single program. And then lastly, I think the future vision to see if we can get some consensus in the country about the vision for Medicaid. I don't think there's any doubt that polling and other data has shown that there's broad public support for Medicaid, but there's also clear that there's broad philosophical and economic disagreements among policymakers and many others on the role of Medicaid, what objectives it should be serving, what are the highest priority ones, and how best to allocate federal and state funding on a go-forward basis. And add to that, and I mentioned earlier that we have an aging population. We're going to have even further spending needs for long-term services and supports, and trying to figure out if Medicaid can continue to play the primary role in financing that, or if it need to think about different alternatives. So I don't know if I've given you any solutions, but what I have hopefully given is at least some of the broad trends that I think we'll all be talking about on a go-forward basis, and look forward to your questions and continuing the conversation. Thank you.
Thank you. Next, we'll hear from Nina Ochorinco-Schaefer, and the floor is yours.
Well, thank you, and thank you for pronouncing my name so beautifully. You must have listened to it online, so thanks so much. So I guess as we're teetering back from Medicare and back onto the Medicaid side, it might be good to kind of remind us of how different the two programs really are. On demographics, Medicare is pretty much a homogeneous group, some mainly seniors, those over the age of 65, and those that are disabled. Medicaid, on the other hand, is a totally diverse program with a very diverse set of populations that are using it. On the benefit and design and administration of the program, Medicare is purely federally run, where the Medicaid program, obviously, is a very complicated partnership with the federal government, where the federal government sets rules, but the states are in charge of implementing the rules. Also, on the Medicare side, as has already been discussed, there's a lot of choice of a variety of different private plans that are available in Medicare, where in Medicaid, private plans typically play more of an administrative function of administrating the program for the states. And on the spending and financing side, unlike Medicare, which has a devoted payroll tax, Medicaid has a very complicated financing arrangement and a formula-based system between the federal government and the states. So similarly, I thought we'd take a bigger step back and kind of look and see what's going on in the Medicaid program. This really trying to illustrate the changes in enrollment in the program. So in 2000, you will see that pretty much the majority, prior to this, most people think of Medicaid when it was first established back in the 60s as a program for low-income, very select groups of people, children, pregnant women, aged and disabled. That's kind of the typical mantra people had. As time has gone on, we've seen things have changed. Here in 2000 even, we still see that the program is seen pretty much as a program for low-income children. Almost half of the program is devoted to that. Now, when we, with the addition of the Affordable Care Act in 2010, the program added a new category of individuals, which were we call new adults, into the program. And that has really changed the dynamic of the program pretty significantly. If you combine both the new adults and those who were previously eligible for Medicaid prior to the Affordable Care Act, they make up now over half of the Medicaid program. So no longer is it a program that's really focused on children or that our enrollment is predominantly children. It really has now kind of has this tether between adults and children. And I would point out too that original projections by the actuaries at CMS actually did not see that the increase in new adults would be as high as they are today. So that's something that's been a surprising change in the trends. So again, just reiterating, here's a difference in kind of how the program has changed just within the last 20 years. The next slide I thought I'd look at is kind of building on a lot of the conversation about the role of private insurance and the role of Medicaid managed care. So like many places in the 80s and 90s, Medicaid managed care started to kind of get some traction. If you will see, mainly in 2000s, it was still focused on children, some disabled, some of the adult population. And now, kind of jumping to 2022, we see one, not only is there a large saturation of Medicaid managed care, and it is grown, but in particular still remains pretty consistent for children and the new adult population, as well as adults in general. This is a caveat to say not all states have managed care. It is different across all the states. Most states have managed care in their states, but there are still a handful that don't. So this is just a national outlook. Every state has a different set of what the penetration is of private coverage in there. The next look, yes, and then the next slide is going to look just at total Medicaid spending, just to kind of reinforce, as has been discussed, that costs continue to rise. And it's not just on one side of the equation, it's on both sides. So federal costs in 2024 were expected to be $925 billion. Over about $600 billion was federally funded and $300 billion about state funded. They were spending about $9,500 per enrollee in 2024. And if we look forward to 2033, really not that far into the future, we will hit a total Medicaid spending of $1.6 trillion. Sometimes this seems dwarfed when we talk about Medicare, because many times if you're in Washington, they only look at the federal side of the equation, and when you're at the state level, you only look at the state side of the equation. This is really important to kind of see the growth and the amount of cost that the program is tapping, not just federal taxpayers, but the state taxpayers. So what are the challenges moving ahead as we look to the next 60 years, I would say? Well, first is that we have this competing benefits, the competition between beneficiaries and the priorities of what the program is. So, again, we have a lot of enrollment among adults, a lot of enrollment among children, but we know that even though the aged and disabled are the smaller population, that's where the costs are, and that's where the cost management really should be focused on. Second, I think that the Medicaid program in its 60 years still has a little bit of an outdated administrative structure. All you have to do is look at the number of waivers states have to use to actually implement and administer their program. We have some states that have continuous waivers that just go into perpetuity. The first Trump administration had even suggested at one point, should we give states 10-year waivers so they're not constantly coming back and forth? So that's another big challenge that we face. And then the last one is kind of the tense financing arrangements. This is not going to change. We saw what happened in the recent reconciliation package. I always tell people in Washington that the financing issues in Medicaid, the fights in Medicaid over financing are not a red state and a blue state issue. They're a federal policy fight over the state policy fight. And that makes the dynamics very tense as we move forward. So what are some of the things we could look forward to? Well, I look at the future of Medicaid through an organizing principle of what do we do, how can we reimagine, it's interesting you use the term reimagine, through the lens of each group. Instead of trying to lump everyone together as diverse as they are, how can we start to kind of segment out the groups and look at what are the needs of those population and what changes could be made to better meet the needs of those. On the benefit and design side of the equation, what kind of flexibility is needed? What's the right role for private coverage among these groups? Is there a different kind of role for private coverage for, let's say, families who are just low income? Or how about the new adult population? What's the role of the exchange or employer-based coverage when we look at health insurance for the population? If we can look at different models, that may perhaps free up opportunities to look at how do we better design and tackle the real cost problems in Medicaid among the elderly and disabled. Revisiting the role of waivers. There is a whole cottage industry. I mean, I'm sure many of you, if you have a state, know how often you have to spend state dollars to actually implement or come up with a waiver and implement the waiver. Are there ways of looking at what the purpose of waivers are and reminding everyone that the point of a waiver is to demonstrate something? If it succeeds, then it should change in statute, not just continue ongoing into perpetuity. So making sure that we're actually translating what we learn in these experiments, in these demonstrations, and translate that to actual statutory changes so states don't have to keep coming back to CMS asking for permission for it. And on the financing side, how do we realign the financing more appropriately? Incentives matter. I think if you remember the first chart that I showed where it showed the growth in the new adult population, I don't think it's a surprise that we saw the significant growth when the federal government was picking up 90% of the cost for that population to enroll them. So I think that we need to have a real kind of realignment of how we're going to finance the Medicaid program properly and kind of find a way to better balance it across all the categories that are eligible for the program. And then in closing, in the long term, I think we do need to find a way to create a very strong safety net. I do think the Medicaid program has an important role in providing care and coverage to those that are in need. And I think the biggest challenge maybe we face is how do we actually bring the federal policymakers together with the state policymakers to find a way to create a path forward on this. Maybe I am trying to be hopeful, but the reconciliation package I think did send some shockwaves across the states and across the healthcare system that Congress actually took Medicaid as their priority in that effort. But at the same time, it might have created that momentum for bringing the states to the table and having the federal government sit down and figure out what is the future of Medicaid for the next 60 years.
Thank you very much, and I'll remind our committee that we will have the time for questions here in just a minute, and so I will open that up shortly. Of course, last, Laura, we'll call on you now to share and look forward to your comments.
Thank you, Representative. It's wonderful to be here and to have NCOIL in our home state. I love seeing so many Georgians and Georgia leaders here. It's really fantastic to know that you guys are all working to stay informed and responsible in your leadership for our state and in your policymaking around insurance. I'm here to talk a little bit more specifically about Medicaid in Georgia and specifically our state's experience with a Medicaid work requirement program and how that might apply to other states as the implementation of H.R. 1 moves forward. So I'll share a little bit about that today. Starting with just a quick look at Medicaid in Georgia, our program covers about 2 million folks. That's about 1 in 5 Georgians, and the bulk of our Medicaid members are children. So about 70% of our Medicaid members are children. In part, that is due to Georgia has not expanded Medicaid to low-income adults fully as it's envisioned by the Affordable Care Act, and so our program looks much more like the 2000 demographic chart than the 2022 demographic chart. Our marketplace and Medicaid systems fit together a little like this, and I don't expect you, everybody to kind of see all the nuances of this, but this chart I mostly display to kind of demonstrate how our marketplace and Medicaid systems fit on top of each other. And for adults in this structure, which is primarily the right side of the chart, actually easier to see here where it's just the adult side, you can see that the eligibility structure for adults in Georgia is a little uneven and can be quite complicated. Even we have an enrollment assister on staff that helps families through both marketplace enrollment and Medicaid enrollment processes, and even with the assistance of an enrollment assister, navigating these kind of Tetris blocks can be challenging for a family and an individual. For adults in Georgia, part of Georgia's unique structure is that we have a program called the Georgia Pathways to Coverage program. This program informed the Medicaid work and activity requirement that was passed and approved by Congress in H.R. 1. And so I'm going to kind of walk you guys through what that program looks like very briefly and the results of the first 2 years of the program, as well as some learnings that we think are helpful for other states as you begin to plan for what that might look like in your state. So the Pathways to Coverage program, which I'm just going to refer to as Pathways, is the only active Medicaid quote-unquote work requirement in the country. It launched in July of 2023, and it's really built for adults with incomes below the poverty line and those who can complete and document 80 hours of work or other approved activities per month. So folks need to be, applicants for the Pathways program need to be a working age adult. They need to be uninsured and ineligible for any other Medicaid category, and again, have that income below 100% of the federal poverty line. That is lower than the Medicaid expansion threshold of 138%, so some people refer to the Pathways program as a partial Medicaid expansion. The second step in qualifying for the Pathways program is that applicants must complete and document up to 80 or at least 80 hours of work or other qualifying activities per month. That can include work, school, volunteering. There are a couple other categories of engagement activities, as they're referred to, and that documentation has to be submitted through our public benefits website called Georgia Gateway. The Pathways program has evolved in its reporting of activities over the course of 2 years. It began with a monthly reporting requirement that kind of informally transitioned into a quarterly reporting requirement, and then officially, as of an extension of our Medicaid 1115 waiver that authorizes this program, the annual reporting is now annual at enrollment and renewal. So when adults apply for the program, they submit their documentation, and then they will submit again when they renew it a year later. I've listed a couple of the acceptable documentation types here. In H.R. 1, Congress laid out that reporting requirements will be at least twice annually. States do have the option to do more than that, but it will be at least twice annually. So that is a difference between Pathways and HR1 for the moment. HR1 also provides different exemptions from the Pathways program. In fact, HR1 I would describe as being a little more flexible and open with its exemptions. The Pathways exemptions are pretty narrow and time limited, and so it tends to be more stringent. We did newly, as a state, add an exemption for caregivers for children who are under the age of 6. In HR1, that caregivers exemption is for children under the age of 13. So that's one example of the difference. But again, in this way, Pathways is a little stricter, and HR1 has a little more wiggle room. So over the first 2 years of the program, we have seen just under, actually I just checked the enrollment data today, and this data is from the end of September. As of the end of October, it's just over 10,000 Georgians enrolled, I believe 10,200-ish. That is 7% of Georgia's low-income uninsured adult population who live in working households. Even at full implementation of the program, Georgia only anticipates about 1 in 4 of people within that population to be covered under the Medicaid program, under this particular Medicaid program. Notably, the program has cost taxpayers $110 million over those 2 years, and only less than a third of those dollars have been spent on health benefits. The bulk of program spending has been invested in our public benefits technology system. Again, we call that Georgia Gateway. The Gateway system had been in dire need of investment and modernization, so those dollars are not misinvested in any way. Certainly the modernization has been a real benefit, but higher spending on health benefits would be a welcome change in program results. A couple of other key takeaways. We have really seen the highest number of enrollments in our metropolitan counties, and Pathways program has really done little to address the higher uninsured rates in rural counties. You can see here that about half of Georgia's counties still have less than 25 residents who have ever been covered in Pathways during the 2 years of the program. In addition, of the completed Pathways applications that have been processed, a relatively low rate have actually been approved for Pathways coverage, and you might think that that means people aren't meeting the work requirements, but in fact, of the applications that were denied, only 1 in 10 were denied because of the applicant's failure to meet those engagement requirements. Most denials are income-related issues, paperwork, and other administrative barriers, so we're really seeing a real administrative challenge in getting folks enrolled. We're seeing, and as this data also shows, we're seeing a similar trend during the renewal period. Almost 2/3 of unsuccessful renewals are due to just being unable to get paperwork completed, whether that is that somebody hasn't received it or can't get it into an outdated system. That has been a real challenge, and so it's not that people aren't still meeting the work requirements, it's really that paperwork and administrative burden. And notably, I don't have data up here, but the work requirement in Georgia has not increased employment or workforce participation among this group. Now, as other states, as states beyond Georgia kind of look towards January 2027 and the nationwide implementation of Medicaid work requirements for those Medicaid expansion adults, there are some steps that states can take, and Georgia has started down some of these paths as well. So we're pleased to see that progress and really heading in an improved direction. I would advise states and legislatures in your role in advising Medicaid agencies and in funding them to update their Medicaid and eligibility and enrollment policies and technology, and making sure that your workforce is supported and compensated well. This is a complex program to administer, and you need to make sure that the technology, the people, and the policies are all ready for that. Updating those systems and paperwork to be as user-friendly and easy to understand as possible, keeping reading levels low, having fewer screens, text message reminders, those kinds of things that really help people move through the program a little more easily and with a little less help. invest in and train those local community-based enrollment assisters. As I said, we have one on staff, and we often get calls. You know, we've tried to get through to our local Medicaid or benefits office. We can't get a hold of them. They're only open on Wednesdays. I'm at work on Wednesdays. Thank you for helping us. So really investing in those local community-based enrollment assisters, they can help walk people through the challenges of a program like this. And making sure there are strong partnerships and relationships between state agencies, community-based groups, advocates, and media so that consumers are aware of the changes that are coming, understand how they can navigate it, and that there's as much transparency as possible. And then lastly, really setting up ahead of time transparent data reporting requirements of Medicaid agencies that are administering these programs so that there's a good understanding for the agency itself, for all of you, and among the public about what isn't working and where the sticky points really are in these programs. So I hope that's helpful for you all and other states. And again, Georgia's starting to head in this direction, so we're pleased to see that and happy to further discuss during the Q&A.
All right, thank you. At this time, we're going to open it up for question and answer. I'm going to take the first question from Senator Tice.
Thank you, Mr. Chairman. I actually have a few comments based on the presentations. So it started out with, we're going to do more benefits with less cost, and I'm not quite sure how that's supposed to happen, but this feels a lot like socialized medicine. Government subsidies tend to create a higher cost, not a lower cost. I give, for an example, when you go to get eye work and you have to pay privately, those costs haven't gone up. I just had a CAT scan that I paid for privately for $100, and I'm nearly positive it would have been 10 times that if my insurance was required to pay. We're doing insurance for well care, which is not what the purpose of insurance was supposed to be for originally, and I'd like to see us get back to insurance for insurance sake. I think that might go a long way to actually solving some of these cost questions. Usage does not equal better health, and so I'm hearing numbers of people covered, but I'm not hearing outcomes, and I would love to hear health outcome data as opposed to numbers of people covered. And so I give as an example, one of the things in Medicaid that my state was doing was paying for the GLP-1s for weight loss with zero accountability requirements whatsoever, which private industry doesn't do. Private industry has major requirements if you're going to continue on that, but we were paying $1,000 per patient with zero requirements that they do anything to exercise or eat healthy, and if they lost up to 5% of their body weight, they were going to be on the GLP-1 for weight loss for the rest of their life at the cost of the government. That is a massive cost for insurance for the state for Medicaid. So I guess what I would like to hear in the presentations is an approach to better health outcomes and not more coverage. So sorry for the speech, but thank you very much for the time.
Isn't that true? All right, so we're going to ask, our next question will come from Representative Hefner. So the floor is yours.
Thank you. I appreciate you guys coming here today. I also can appreciate that we are looking towards how much, Medicaid costs are rising. But we're working on a platform since 19 clickety-clack, and it leaves people dependent on benefits without any space to grow. In Oklahoma, we have like 58% of people with disabilities that don't have a job. So we talk about, if we're also talking about the big picture, there's so many other things that have to be modernized instead of just looking about decreasing the people that we're going to, support with these benefits that we have told people to rely on. So I wish in the conversation that we could have about reducing the cost of Medicaid, that we also talk about employers hiring, wages, Social Security reform, all these things. It's a domino when we just turn off the switch on one thing. And so there are a lot of families out there, especially waivers. I hear comments about people getting rid of those state-matched Medicaid dollars for waivers, and institutions I heard which cost us a whole heck of a lot more and is ripe with abuse. So if we talk about this, we can't vacuum it by just talking about reducing Medicaid without talking about all these. Thank you.
All right, Senator Utke.
Thank you. And I've got a question that went back to two sets of slides ago, and I believe it was with Nina, if I pronounced that right. Your slide showed two different dates on it, but the second or most current date, you referred to new adults. Who's included in that category?
Those are the individuals that were made eligible through a new category during the Affordable Care Act. So new adults that were previously not eligible for Medicaid through a normal pathway. They created a new category that is eligible for Medicaid, up to 138% of poverty for childless adults, most of it.
Thank you.
All right, are there any last questions before we move to our next? All right, well, at this time, I just want to thank our panel again for participating today and for everyone's patience in the conversation. We really appreciate it. I also want to thank Patrick and, of course, Will for allowing me the opportunity to moderate today. Next, our public policy makers and staff are welcome to attend the Institute's Griffith Foundation Legislator Luncheon on this floor, and then we'll meet back in this room at 2:15 for the Workers' Compensation Insurance Committee meeting. We're adjourned at this point.